The following show is for educational purposes only. It is not intended to diagnose nor treat any medical condition. Any information or recommendations provided should always be discussed with your healthcare professional. Welcome to another episode of the Patient Talks. I'm Frank Smith, a family practice physician assistant, and today we're going to be discussing carpal tunnel syndrome. If you've recently been diagnosed with carpal tunnel syndrome, odds are you presented to your clinician with complaint of some pain and numbness or tingling in the thumb and the first three fingers of the hand. Usually it does not involve the pinky. If it's been going on for a while, it has started to really interfere with your sleep and some of your day-to-day activities. Carpal tunnel syndrome is pretty common, but not many people really understand the underlying problems that are producing it, and so we're going to discuss those today. We're going to start with just some very basic anatomy. If you look at most joints, for example, an elbow or a knee, that's just a very straightforward hinge joint. A hip is a very straightforward ball and socket joint. But the wrist, if you've ever seen an x-ray of the wrist, it looks like somebody took a perfectly good bone and hit it with a hammer and shattered it into pieces. In this case, 8 to be exact. But that is what gives the wrist all the movement and flexibility that we have. On the front part of the wrist here, the anterior part of the wrist, there's a notch within the bones. And that's what allows the veins, the arteries, and the nerves to supply the hand. Meanwhile, going across the front of it is a thick connective tissue layer called the retinaculum. So we've ended up producing a notch, and then we've laid something over the top of it, so we've produced a tunnel. Carpal bones is the other name for the wrist bones, carpal tunnel. And what happens in carpal tunnel syndrome is that thick retinaculum across the top gets even thicker and starts to press on the underlying structures. Nerves are very, very sensitive to anything like that, and they will let you know about it. As far as what caused this, there are several things that come into play. One of them is genetics. If you have carpal tunnel syndrome, odds are you know someone in your family that has carpal tunnel syndrome as well. Positioning matters too, activities. This one isn't so much about repetitive use as it is positioning. One of the other names for carpal tunnel syndrome is keyboardist wrist, and if you think of the positioning of the wrist when you use a keyboard, that comes into play. If you're old enough, it's also known as typist wrist. There are some medical conditions that make it more likely to happen as well. Hypothyroidism contributes to it. Diabetes does as well. Rheumatoid arthritis, being overweight or obese. And it seems to show up pretty often in pregnancy too, although that one usually self-resolves a few months after pregnancy. As far as treatment, your clinician has probably already told you to either pick up or has dispensed what are known as cock-up splints. And what we're trying to do is we're trying to position the wrist in its neutral position. And if you think about the anatomy I described to you earlier, it makes a lot of sense. What we're trying to do is hold that wrist in a position to let that retinaculum thin and get the pressure off of the nerve in that area. We usually tell the patient to wear them at night, but the truth is the more you're able to wear them, the more likely it is to actually have a positive impact. It can take a while too. I usually tell patients we're looking at 1 to 2 months before you start to get some significant improvement on it. Anti-inflammatories are a good place to start too. If you don't seem to be responding very well to just the splints and anti-inflammatories, your clinician may talk to you about an injection into the wrist. And what we're doing at that point is we're placing a steroid right into that retinaculum, that thick top layer, and we're trying to thin it somewhat by adding the steroids into that. Between the splinting and the shots, somewhere north of 70% of patients respond to that and it's over. Some patients do also need physical therapy or occupational therapy. If you haven't responded to any of those, your clinician is probably going to order what's called a nerve conduction study or a velocity study on the nerves in your arm before referring you out for surgery. And what they're trying to do is see how well are the nerves actually conducting electricity, if you will, how well they're conducting the signal, because that's going to tell them just how severe of a carpal tunnel syndrome you have. Your symptoms alone aren't really enough to tell the story. As far as the surgery, I'm going to leave most of that to the surgeon where it belongs. But the basic concept behind doing a carpal tunnel release is they're essentially going in and making an incision in that retinaculum to get the pressure off of the nerves so they can go back to their normal function. So that's it in a nutshell. That is carpal tunnel syndrome. I hope I've given you some good information. I hope you found it interesting. If you have, please click the like and subscribe button down below. I will be back next week. Until then, get better and make me look good. Have a good week.